So as I begin, no disclosures, no financial relationships to the contents of this activity. And yeah, we're gonna go into the assessment and screening for substance use disorders. Hold on. Okay. Well, let's start with this. So these are some of the updated slides. I mean, I think in terms of the data, this is past year prevalence of substance use based upon the National Survey on Drug Use and Health. And this is from the 2019, remarkably constant actually with the 2020 data, which is the most recent one that's available. But this was sort of nicely presented. So that's why I'm using this slide. And this is courtesy of PCSS, which is the provider's clinical support system, right? So if you look at all the people, you can see here, let's see, pointer, I'm going to use a laser pointer. So this is past year prevalence. So just in the past year, 7.5%, 8% of people age 18 or older actually met criteria for a substance use disorder, so kind of active substance use disorder. And if you then further zoom in on that, you can see that about 38.5% struggle with illicit drugs, 73% struggle with alcohol use. So out of this 19 million individuals, and 11%, which is another 2 million individuals, struggled with both illicit drugs and alcohol, right? So about 19 million individuals in the United States with a substance use disorder, about 51 million individuals with a mental illness, and about 13 million actually with a serious mental illness, and then this great big overlap, right? So one of the things I know we often bring up is that substance use disorders don't happen in isolation. Often when there's a substance use disorder present, there is a co-occurring psychiatric illness and vice versa. And when there is a substance use disorder present, as this hopefully points out, there is often a second substance use disorder. And I think that kind of, for me, really highlights the importance of screening. This is not happening in isolation. And if we're not screening for it, we're often missing substance use disorders when they might exist, right? And then look at this. This is National Survey on Drug Use and Health from 2020, right? Received any substance use treatment in the past year among people aged 12 or older who had a substance use disorder. And you can see this is the percentage. So you can see how few people are actually receiving treatment consistently under 10% across all groups. And interestingly, in the NSDUH, they consider mutual help as part of the treatment. So one of the options is, did you attend mutual help groups? And that's actually the #1 category that people report seeking treatment through is mutual help. So when you get into this is percent receiving any substance use treatment at a specialty facility, so place like where Dr. Jacobson and Dr. Gadomski are sitting right now, or where I'm sitting right now, you can see how low that number is. About 3% when you're looking at 12 to 17 years. 3% even when you go up to that 18 to 25 age range. So very little. So specialty substance use disorders treatment is extremely difficult to access, right? So far we've established that substance use disorders are common. They don't happen in isolation. They often happen with other substance use disorders or mental illnesses. And the last two slides have hopefully shown or demonstrated that specialty substance use disorders treatment is extremely difficult to access. And this is always striking to me, that 98% of people, these are all the people who did not receive that substance use disorder treatment at a specialty facility, a majority did not feel like they needed treatment, right? So there is often this gap where people don't feel they need treatment. So let's see here. But on the other hand, so while specialty treatment is so hard to access, primary care, for example, is much more commonly accessed, right? Emergency department visits are also, not uncommon, as Dr. Warwick, who's on, can attest to. So that's the opportunity. We've got substance use disorders. People are unable to or not willing to access specialty treatment. They are accessing primary care. So can we hopefully leverage that? And can we use medical settings to help people with substance use disorders who may never go to a subspecialty treatment? Maybe don't need that. Maybe they need that level of care. can we actually help those individuals? And how do we best reach those patients? And I think that's at the heart of, in some ways, screening and assessment, right? Because screening and assessment, and we'll differentiate between the two here in just a minute, help providers, help all of us understand what patients' needs are and match them to the right level of care, and help providers track symptoms over time and adjust treatment accordingly to best match the level of care someone needs with the treatment that they need, right? So there's been an evolution. That's what the next couple of slides are really getting at. There has been quite an evolution in how we have approached treatment for substance use disorders. Historically, there was this complication-driven treatment. Screening wasn't happening, right? No one was receiving treatment. Then there would be some, some complications, and that's when we would provide treatment, right? Treatment of complications with no continuing care, which, as we know, leads to very high rates of relapse, recurrence of use, continuing problems, and doesn't really help. Then we get to this diagnosis and program-driven treatment, where the treatment is really determined by the program. What does the program offer? And that's what we'll try to match everyone into, right? But our present really is this client-directed, outcome-informed treatment. And again, these are slides from Dr. Lindsay. She's allowing us to use them, where we assess the participant and we really see what the needs of that individual are and best match the treatment to those needs as they exist, right? And I think a key thing here is continuum of care. Again, I'm not going to go into this slide in great detail, but I do want to highlight that, ideally, again, if we follow this model of matching treatment to the needs of the clients, there's going to be ebbs and flows. Maybe there are times where the patient needs a higher level of care, when we might think about a rehab or maybe an IOP. And maybe then after that, as their needs decrease, they maybe come to a specialty treatment, outpatient setting, or even primary care or general mental health setting. And this can change, again, depending upon the needs of the client, right? So that's really where it gets to. So now we start getting into screening. I think all of this starts with screening. So these are the risk levels, right? Where, majority of people are low risk for substance use, or maybe are abstainers. They don't use substances at all. And of course, in that setting, no sort of intervention is needed. We provide positive message and continue to just follow them as we would. But then we start getting into this top of the pyramid, right? With risky use levels, and then kind of getting into harmful, and then a use disorder, right? And this is where we start matching the appropriate level of care to what the needs might be, right? Maybe for some folks, a brief intervention will do the trick, or maybe for some people, they might require a brief treatment, something a little more intense. And certainly the individuals with a substance use disorder are gonna need treatment for that substance use disorder. Kind of moving forward, this is going into ASAM criteria, which New Mexico does follow. And ASAM criteria are really designed, again, to appropriately match patients to the level of care that might optimally benefit them. And it's very interesting. So I think according to ASAM patient placement criteria, it goes from screening to diagnosis, but then it gets into things like severity, readiness and relapse potential. And all of those are used across these settings. So not just biomedically, but also, is the patient acutely intoxicated right now? What is their risk for withdrawal? How are they doing from an emotional standpoint, right? How ready are they to accept treatment? What is the potential for recurrence of use? What is the recovery environment? And all of those factors figure into ultimately matching the patient to the right level of care, which can range from simple outpatient to intensive outpatient, all the way to medically managed intensive inpatient treatment. And all of these factors go into that decision-making. Whenever I read this, one of the first thoughts I always have is that this is wonderful, but unfortunately for many of us here in New Mexico and in other parts of the country, the reality is that some of these levels of care are nearly impossible to access. And maybe that's something many of us can relate to. So we're always doing the best we can, right? Here at UNMASF, we're an outpatient facility. and we're often treating patients who, per ASAM criteria, need a much higher level of care, but unfortunately, there is nothing available. And so we're kind of doing our best to treat our patients, right? And I'm kind of gonna go forward here. Let's see. Okay, so that brings me to the SBIRT model. So ASAM criteria, and the message there in the last few slides really was that data does show us that when we can match the level of care to the needs of the patient, outcomes are optimized. Right? Perhaps it's intuitive, perhaps it's no surprise, and data does show that. SBIRT, that's something many of you, I'm sure, have invariably heard the word SBIRT. So we're going to introduce that, right? So SBIRT really stands for Screening, Brief Intervention, that's the BI, and Referral to Treatment, RT. And SBIRT really is a model that's designed to do exactly what we've been talking about thus far, right? Screening individuals and then matching them to the right level of care. Everything starts with screening. Right? Screening is that initial piece that allows us to identify people who may have a substance use disorder, but maybe they don't yet have a substance use disorder, but their substance use is entering that hazardous category where it's posing a risk for them, and we need to do something, right? So it's really, the idea is not to just pick up people who are already have developed a substance use disorder, but hopefully identify that harmful use a little bit earlier. And that starts with screening, right? And it uses, of course, standardized screening tools. And screening can occur in any healthcare settings. And as I was hopefully making the point early on, primary care settings, emergency departments, I think are great examples of where screening can happen when patients access it. Brief intervention, right, is sort of exactly what it sounds like. It's brief, it's limited, and it's designed to engage a patient who's starting to show some hazardous, some risky behaviors in a short conversation. It's often motivational interviewing forms kind of the basis for how brief interventions occur, though they're not strictly motivational interviewing, but the spirit of motivational interviewing is often present in these brief interventions. There is often a feedback built in. And National Institutes of Alcohol, NIAAA, does have actually a website called Rethinking Drinking that I love to recommend. And it actually has a tool where the patient can sit down on the computer, provide some answers, your age, your gender, your how much do you drink, what's your drinking pattern, and then it gives instant feedback, like you drink more than 95% of people. These are the risks that you have, and these are the things we recommend. So there are even computerized brief intervention algorithms that are available through NIH. And then referral to treatment, of course, level of treatment matched to the screening tool and or the ASAM criteria, right? So brief interventions, there are multiple models out there, but in general, these are the common components of brief interventions. So you've done the screening. We know someone has a hazardous use pattern. Thank you, Rachel, for posting the website to Rethinking Drinking. So now brief intervention, right? So it often starts with providing information and feedback. One tip I would add is that, I often ask for permission. Is it okay if I give you some information? Or is it okay if I give you some feedback about what we think about what you described in terms of your drinking, for example? And I think simply asking that permission creates a more collaborative environment, right? Where I'm not just throwing information at someone, telling someone what to do. Understanding patients' views of their use, right? So that's that eliciting information. Again, kind of informed by motivational interviewing, right? Asking for that permission, eliciting patients' views, patients' experience, and coaching the patients to change their perceptions about their use. So it's not strictly motivational interviewing anymore. It often can start to change. Encouraging the patients to discuss their views on how, kind of what's happened, what's been the consequences of your use, and how might they consider changing. And then here, this is sort of unique to some of the brief interventional modalities, right? Where, oftentimes we'll say advising patients in clear but respectful terms, right? So advising to decrease or abstain from their substance use. And there is a model was also designed by NIAAA of brief intervention for alcohol use, where I might say, if I'm following that model, I might say, as your physician, based upon what you told me, right, I would recommend that you stop drinking altogether, right? Potentially, that could be something I say. So there's a clear advice built in some of these models. And then you go into, how does the patient feel about it? What could be some barriers? What might be some motivators why they want to do it? And start to come up with plan, start to come up with specific strategies that might keep the person from using substances, and establishing follow-up, right? So kind of following up, continuing to track it, not losing sight of it, are all part of brief intervention. There's even an SBIRT app available, and this is the link to the iTunes App Store where that is available, right? So, and this is kind of another way of looking at it, where kind of moving forward, right? So routine, the screening is routine, right? And if someone is low risk, prevention, right? No further intervention is needed. If someone is moderate risk, then you do this brief intervention as we talked about. Education is provided. Moderate to high risk, brief treatment might be recommended, where there are components of brief motivation enhancement therapy built in. And if someone has severe risk or substance use disorder, that's really the group that ought to be referred to specialty treatment, right? And we talked about screening a little bit already, so I'm not gonna, again, go into this too much. Screening versus assessment. So screening is what happens at first, right? Soon after seeking services. Screening might be for substance use or for other behavioral health concerns, can be used in a variety of settings, and can assist in the referral to treatment. So it's the initial piece, whereas assessment usually happens after the screening. It's more in-depth, it's more detailed, and it's really getting at how do we best, right? It kind of the nuances, what is best going to help my patient. So assessment is something that happens after the screening, and it often takes into account co-occurring disorders, kind of those nuances to best help the patient. Right, so that's the difference between screening and assessment. These are just some of the criteria, some of the commonly used screening tools for adults and adolescents with substance use disorder that are listed here. One caveat, and I actually shifted out one of the slides here already, so I'll go into that. The CAGE questionnaire, many of you may be aware of, it is alcohol specific. It's simply 4 screening questions, right? If someone scores over 2, it's suggestive of a lifetime diagnosis of a substance use disorder, right? And it's important when we're doing this screening to know the standard drink size. So for example, someone might say, I had a patient who says, I drink 2 beers a day. He's a otherwise healthy male under the age of 65. Right? So that's technically not in a hazardous drinking category. If he drinks 2 beers a day, doesn't drink more than 14 beers in any given week, right? So he falls under that. But then when you ask him what he drinks, he's drinking, 2 pints. So total of 32 ounces of beer. That's about 7% to 8% alcohol content. So all of a sudden, although he's only drinking 2 beers, right? In reality, that does go over, kind of well over that. So it's important to know what a standard drink is, correct? And these are the questions in the CAGE questionnaire. Have you ever felt you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt guilty about your drinking? And have you ever had a drink first thing in the morning, right? And if someone scores over 4, it's highly suggestive that the person, in fact, has an alcohol use disorder. So it's a quick screener, can very easily be done. Audit and Audit C, alcohol use disorder identification test. It's also a validated scale. The full audit is 10 questions. And Audit C is actually just the first 3 questions of the audit. And if, in the Audit C, which I have here in the next one, right? And the first 3 questions are the Audit C. How often do you have a drink containing alcohol? How many units of alcohol do you drink on a typical day when you're drinking? And how often have you had 6 or more units if female, or 8 or more units if male on a single occasion in the past year? And on the audit C, if women score over 3, if men score over 4, that's actually considered a positive screen, right? So it really suggests that the person might be drinking in an unhealthy manner. This is similarly the DAST, which is the drug abuse screening test, comes in 10 and 20 item versions. There's an adult version and adolescent version. We use it here at ASAP. It does align with ASAM criteria. Then there used to be something called NM Assist that we used to talk about. That's the NIDA modified assist. That's been replaced. SAMHSA now recommends using this tool called TAPS, which is a tobacco, alcohol, prescription medicine, and other substance use tool, TAPS. And I've included a link to it. It is available online free of charge. It's very similar, actually, I think, to the NM Assist, where there is a first part where you ask basically if someone uses these different substances. So it's like a brief, it's sort of the screening piece. And then if someone scores positive, it goes into the second part of TAPS, where it goes into a little more in depth and does a brief assessment, right? So it's actually a great tool to use. It's available online. And I think one of the benefits is that, it can hit multiple substances, right, through kind of this one tool. Then there are these symptom trackers in terms of other screening tools, which include things like COWS and SIWA. Not very helpful, I think, in terms of diagnosing a substance use disorder. They're more going to help with someone's withdrawal symptoms, right? And these are some of the mental health screening instruments that we've included. Although beyond the scope of this discussion, commonly used ones, PHQ-9, I know many of you use in primary care settings, same with the GAD-7. So those are out there. And again, once the screening is done, if we know someone has a substance use disorder, then we might go into assessment to gather more information. Assessment is what comes after, right? And in assessment, we start getting into all of these things, right? Demographics, presenting problem, kind of things we do as clinicians, review of systems, medical history, psychiatric history, social history, right? Legal history, things that might impact the course of the illness or the course of the treatment, and coming up with diagnosis and plan ultimately, right? And this can include things like collateral interview, chart review, assessments. There are some assessment tools that are available, in my experience, we use them a lot more in research settings, but these certainly can be used, are available. So we will end here.